Our mission statement. Our focus is to offer an international community for healthcare students with passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders.
Thank you, Cooper. First, I'd like to welcome all of our established NCODA professional student organization chapters: South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Sciences, University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri, Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida College of Pharmacy, University of Utah College of Pharmacy, Howard University College of Pharmacy, Temple University, Shenandoah University, Oregon State University, University of Toronto, and the University of Colorado. We'd also like to welcome all of our In Progress NCODA chapters. Thank you for joining us. And finally, welcome all students. The student educational talks are available to all students regardless of NCODA membership. Currently, we're 3,500 plus members and over 540 practices strong. Working together, we become stronger. Stay up to date with all of our information. We encourage you to follow our Facebook and our Instagram pages. You can scan those QR codes here on the screen now. And for any other information, make sure to follow our national NCODA LinkedIn page. I'll go ahead and leave the screen here for you to take out your phones and scan that. Next, I'd like to let everybody know registration is now open for our first annual professional student organization meeting. For this meeting, it's going to be focused on an oncology student pharmacist career journey. It's going to be taking place September 16th and 17th in Detroit, Michigan at the Westin Detroit Metropolitan Airport. There's going to be a welcome reception as well as a networking event hosted at the Henry Ford Museum. And there's going to be a live band and a great opportunity for you to connect with not only key oncology leaders, those residency programs, fellowship programs that are in attendance, but also other students who are like-minded like yourselves and have a passion for oncology. We're also going to be featuring a keynote speaker, Tim Winton, and he is the CEO and president of Taiho Oncology. We're also having other keynote speakers, Lori Pierce, the ASCO president, as well as Marty Whalen with BMS. Next, I'd like to welcome our first speaker for the evening, Linda Schnell. She is the Hematology Therapeutic Area Manager with Genentech Bio-Oncology. Linda, I'll turn it over to you.
Very good. Thank you, Austin. Can you hear me okay?
Yes, we can.
All right, very good. So thank you everyone for attending tonight. I hope your summer is going well. I am here to talk to you about CLL, which stands for chronic lymphocytic leukemia. And before we really get into the disease state of CLL, I think it's really important to spend a little bit of time on this particular slide, which is the origin. It's the cell that CLL originates from. And as you can see,
one second. I'm having trouble seeing your screen right now. Cooper, can you see it okay? It could be my internet.
Linda, I don't see anything. It just says Linda has started screen sharing.
Okay, oh, here we go. My screen is up, so.
I'm happy to bring up mine if
we need to, huh? Yeah, it says I'm screen sharing and it's right in front of me. So why don't you bring yours up as a backup?
Okay, so you have to stop sharing yours. Can you see this?
Yes,
Oh, it's perfect.
very good. And if you could just make it a little bit larger. That's perfect.
Too big?
A bit, just ever so slightly. So I'm going to keep going while she kind of perfects the screen. So again, this is the B lymphocyte, which is where CLL actually originates from. So if you think about lymphocytes, they're part of our white cell, of course, our white blood cell. And there's two types of lymphocytes, the T lymphocyte or the B lymphocyte. And this is a depiction of the maturation of a B lymphocyte. B lymphocytes really, most, if not, well, not all, but many of our hematologic malignancies arise from B lymphocytes. And I'll kind of point out that as I go along on this slide. So first of all, if you can just direct your eye to the stem cell, and that's where all our blood cells start out as. And then again, this is a B lymphocyte, so it's showing the maturation, all the different phases that it goes through until it becomes a mature plasma cell at the very end. And of course, our plasma cells make our antibodies and our immunoglobulins. But before it gets to be a plasma cell, as I say, it goes through all these different stages. If the mutation or change or error, if you will, occurs during each one of these maturation sites, that will determine what type of blood cancer it will develop into. So again, it depends on where the mutation occurs that will determine what type of blood cancer it will become. So for example, you can see on the slide, it says CLL under the immature B lymphocyte. If the change or the mutation occurs during that immature phase, the cancer will become CLL or chronic lymphocytic leukemia. If it becomes mutated during the mature phase, you can see it will become follicular lymphoma, something completely different. Something that's not listed here, just for your own edification, if it becomes malignant at the germinal center, that's usually going to become a diffuse large B-cell lymphoma. And then plasma cells, some of you probably know, the disease of plasma cells is multiple myeloma. And then kind of on the other end of the spectrum, you can see if it becomes a cancer at the beginning, at the stem cell stage, we think of more AML or acute myelogenous leukemia, excuse me. And if it's in the pro-B, it would be more of an ALL. So kind of an interesting picture of showing you where the mutation occurs and what cancer it'll become. The other thing I'm just going to quickly point out on this slide is that you can see during certain phases of the maturation how there's little orange proteins on some of the cells, and that's CD20 expression. It only occurs during different parts of the maturation. And if those CD20 is present on the B lymphocyte, then we're able to target with an anti-CD20 monoclonal antibody. And I think I can move on from here. I just want to say one more thought, but you can move on. That's fine. One of the easiest ways to think about CLL is that it's an accumulation of the B lymphocyte that I just spoke of. So it's like so many of our cancers, we think of this rapid proliferation. With CLL, this chronic lymphocytic leukemia, it's different. It's more of this slow growing kind of chronic condition where the cells just don't want to die and they just pack the bone marrow. If you've ever heard that phrase where the patient's bone marrow is packed, it's packed with these B lymphocytes in the case of CLL. They just don't want to die. They don't accumulate real fast. They just accumulate slowly and don't die. And that becomes important when we talk about some of our treatments. Okay, so CLL overview. As you can see, it's one of the most common, in fact, it is the most common diagnosed form of leukemia in adults in the United States. This slide is a little bit old. In 2019, it has the estimated. The up-to-date estimate for 2021 is about 21,250 patients will be diagnosed with CLL. The median age is 70. So this is a disease of older people. Although 70 is not sounding quite as old as it used to for some of us, but 70 is considered it's an elderly disease. And the prevalence is definitely increasing. Not necessarily the incidence, but the prevalence is very high because people can live quite a long time with this disease. Remember, in its name, it even has chronic lymphocytic leukemia. This is also a disease that's more common in men than women, as many of our hematologic cancers are much more common in men than women. And it's incurable. So CLL is incurable and follows a slow, kind of smoldering, indolent course. However, and it's quite variable. There's some patients who maybe will only live 2 years with it, and there's other patients who go on to die from something else. In fact, may not even ever need treatment for it. So I'll explain that a little bit more as we get on, as we move on. Many of the patients with CLL have at least one coexisting medical condition. And why is that? It's because they're older. Most of the time, once you're over 70, you have some kind of a medical condition, and that can be as simple as mild hypertension. But most of the time, they do have one existing medical condition. And again, the estimated amount of deaths from CLL is, in 2021, it's a little bit higher, just over 4,000. But we've really affected that death rate in the last, I'd say, 5+ years due to all the new therapies that have come out as of late. Clinical presentation for CLL patients. What's very unique about this disease is that patients are often asymptomatic at diagnosis. The percentage is actually quite high. 70% of patients have 0 symptoms. And it's found incidentally when they're at their doctor for one of their coexisting medical conditions or for an annual physical. So again, 70% of the time, CLL is found incidentally by a CBC. And I'll talk about how we diagnose it in just a moment. The other 30% of the time, patients present with symptoms. They could be what's listed there as constitutional B symptoms. So what are B symptoms? They are an unexplained fever. Usually that's intermittently lasting for more than around 2 weeks. Unintentional weight loss, and usually that's around greater than 10% of body weight within a 6-month time frame. Or night sweats that wouldn't be due to an infection or menopause. But of these B symptoms, only about 5 to 10% of patients are diagnosed with B symptoms in CLL. B symptoms are much more common with more aggressive hematologic diseases such as diffuse large B-cell lymphoma. But as I said, about 30% of patients do have symptoms if they're not part of that 70% that are asymptomatic. Most commonly, what that would be is not the B symptoms, but lymphadenopathy or enlarged lymph nodes. And that's really anything over, if you remember from your biology or anatomy class, average lymph node is about 1 centimeter. So if they're enlarged over that, that is the most common presentation if they're going to have that any symptoms. Patient may also present with anemia or thrombocytopenia. And why is that? Again, remember, CLL is characterized by that packed bone marrow. It's full of lymphocytes in many cases. And so it kind of crowds out the red blood cells and the platelets, causing anemia and thrombocytopenia. Next slide, please. And I just want to let you know there are not a lot of slides here. So if I feel like I'm spending a lot of time on each slide, there's only around 10 slides total. So CLL, another unique thing about it, besides so many patients being asymptomatic, is that in order to evaluate and diagnose these patients, it's really, really easy. It's one of the most easy and, for lack of a better term, cheap or low cost disease cancer to diagnose, because all that has to be done is a peripheral blood draw. And the blood is drawn, and if the patient, they look at a CBC, and the hallmark of CLL is lymphocytosis. So if the lymphocyte count is greater than 5,000, greater than or equal to 5,000, the physician is going to suspect CLL. However, we have sometimes lymphocytosis for other reasons, right? We can get that with chronic inflammation or with an infection. So the pathologist has to check for one more thing to assure that it's CLL diagnosis, and that is the immunophenotype. So we can go to the next slide. So the pathologist will do flow cytometry on the peripheral blood. And I'll just call your attention to that middle section there, which is showing the immunophenotype characteristic of CLL. And if those cell surface markers, just like the little orange cell surface marker that I showed earlier, that was CD20, if on the peripheral blood they see positive for CD5, CD23, CD19, and then dimly lit for that CD20, then this patient can have a definitive diagnosis of CLL, and they must be CD10 negative as well. So this isn't for anything for you to remember, but what it's just showing is that the immunophenotype has to have this exact address, we sometimes call it, along with the lymphocytosis, with a count greater than 5,000 in order for it to make a definitive diagnosis. And sometimes you'll see the immunophenotyping done through immunohistochemistry, and that's usually done on tissue samples, and flow cytometry is usually reserved for blood samples. Next slide, please. So how is CLL staged? Once again, I'm just going to defer to the simplicity of staging. It's very simple to diagnose, and it's quite simple to stage. And I'm comparing that to other cancers. When I think about staging, so many other cancers can be much more complex than this. And there's actually two staging systems that are used for CLL. The Rye staging system is one, and that's more commonly used in the United States. And the Binet staging system is used more commonly over in Europe. The Rye staging system incident is, kind of as an aside, was named after Dr. Kanti Rye, who some of you may actually, that name might ring a bell. He's I believe he's still a practicing hematologist out in the New York area. Kind of the grandfather of CLL, if you will. He's been treating CLL for many, many, many years, and he coined this staging system. Both staging systems, whether they're using the Rye staging or the Binet, rely on a physical exam and a CBC. Again, quite simple. Does the CBC show lymphocytosis? And does the patient have lymphadenopathy or organ enlargement? So I won't go through each one of these stages, but to suffice it to say, again, whether you're using either one of these staging systems, again, it's just going on how much of the lymph system is involved. And that can be told by looking at either their CBC and their physical exam. And as you can see on both of these staging systems, the further down staging you get, in other words, the high risk or Binet stage C would be if the the cytopenias are present. So is that marrow packed? Does the patient have anemia and thrombocytopenia as a result of that? That's going to put the patient at a higher risk for a poorer prognosis. Next slide, please. So in addition to staging, there's other factors that can help predict survival in CLL. And we're still learning about a lot of these, but one that is most commonly checked for and very well known is deletion 17p in CLL. If a patient is 17p deleted, they do have the poorest prognosis relative to the other cytogenetic abnormalities. Thankfully, only about 7% of patients present with a 17p deleted disease. However, it's really important to note that this deletion of 17p can actually be acquired as the disease progresses. So the patient could be negative upon diagnosis, but once they're treated and maybe they go into remission for a while and then they relapse, which is kind of the pattern that happens with CLL. They go into remission and then relapse, go into remission with treatment and then relapse. With each remission / treatment, a patient can acquire a 17p deletion. So even though a small number is 17p deleted on diagnosis, further on into their disease, it can be upwards of 50% of patients will have 17p deletion. And what does that mean? It means that it's more an aggressive disease and harder to treat. Deletion 11q is the next prognostic factor or genomic aberration that is seen that comes with a poor outcome, followed by trisomy 12. And then you can see down in this case, 13q deletion actually indicates a more favorable outcome than patients with some of these other aberrations, as you can see listed above that 13q. And then some unfavorable prognostic factors additionally are increased age. Age is never a good risk factor for particularly cancer. In fact, as another aside, age is the #1 risk factor for all cancers. And another unfavorable prognostic factor is advanced stage. Again, if that Rye or Benet stage is more on that advanced end, it's fairly intuitive. If the patient has a short lymphocyte doubling time, that will also predict a poorer prognostic factor. And what does that mean? Just really what it says, if the lymphocyte count doubles in less than a year. So the patient's seen, let's say 3 months after their initial visit, and their white count or their lymphocyte count, say, is, I don't know, 42,000, and they come back 3 months later, and maybe it's already up past 100,000. That's not a good sign. Elevated beta-2 microglobulin is another poor prognostic factor, as well as you can see the other things listed here. Some of these are still a little more in the clinical trial stage as far as the ZAP70 and expression of CD38. The last one I'll speak to is the unmutated IGHV. About 40% of patients do have unmutated IGHV upon diagnosis, and that too puts that patient in a little bit of a poor prognostic category. Next slide, please. So we're on our last couple of slides. In treating CLL, I don't know if any of you ever heard of watchful waiting. But a lot of times that's what happens with CLL, because so many patients are asymptomatic. Many patients are in that early stage disease and maybe don't harbor some of these poor prognostic indicators. They can literally just be watched. I've heard patients refer to it, however, as watchful worrying, because it's just kind of unsettling to know that you have a cancer and it's not being treated. A lot of patients tell us that they go home and they tell their family, their grandchildren or their children, I've been diagnosed with a leukemia and I'm not being treated. But that's very, very, it's common. In fact, about a third of patients with CLL don't need treatment right away, and they can just be watchful waited, which means, oh, every 3 to 6 months they'll pop in and have their CBC drawn, and they'll be assessed for any organ enlargement, any lymphadenopathy, any symptoms that they're having. The other third or so of patients will need treatment right away. And then the last third of patients, and this is roughly somewhere in there, again, won't need treatment ever. I'm sorry, the first third won't need treatment ever. The second third will need it right away. And then the last third won't need it right away, but eventually will. And so you might think, well, how do you know if you need treatment or not? These things listed here under the bullet points, this is going to dictate if the patient should be treated or not. So do they have progressive marrow failure? Again, I've cited this a few times as indicated potentially by some of the anemia and thrombocytopenias. Do they have massive or progressive or symptomatic splenomegaly, which is often seen with CLL? Do they have massive nodes or progressive lymphadenopathy? And when we say massive, we're usually thinking around, somewhere in the ballpark of 10 centimeters. Do they have progressive lymphocytosis, which we've already spoken about? Do they have autoimmune anemia or thrombocytopenia that isn't responsive to standard therapy? And then again, do they have any of these constitutional symptoms? Defined as those B symptoms that I already described, or even significant fatigue, where they'd have an ECOG performance score of 2 or worse. And then the next and final slide, you can advance it to the next slide, is talking about factors that affect treatment options. So treatment decisions in CLL aren't going to be the same for everybody. So it's going to depend on the patient's age, their performance status, again, those coexisting medical conditions, as well as the cytogenetic prognostic factors that we looked at. Many times the younger patients might get a chemotherapy regimen, although that's changed quite a bit in the last 5 to 10 years. We're using much less chemotherapy in CLL and much more targeted therapies. But all of these factors will be considered in choosing the therapy for the patient. And in fact, we're even to the point with therapy options for patients in CLL where there's a couple, 2 or 3, that would all be very viable options. And the physician will talk to the patient and family about which seems to fit their lifestyle even. Is it a IV? Is it an oral? Is it a treat to progression, or is it a fixed duration treatment? So all those kinds of consideration are taken when deciding on a treatment. And then the last thing is what are the treatment goals? The goals can be different, although most of the time they include both of these things. Relief of symptoms. Obviously, if a patient has a large spleen and it's affecting potentially their breathing or their satiety or just their comfort level, you'd want to relieve that. Are they having fevers, night sweats, that kind of thing? Or is the goal just to extend the time until the cancer progresses again? Is it to extend that remission time, get them in a nice long remission? Because we all know it's eventually going to come back, unless of course they die of something else first, because these patients are elderly. But is that the goal? Is it more to get them in remission longer, or is it immediate relief of symptoms? So all the factors to consider when thinking about disease treatment options. And I think for the sake of time, I am not going to get into the 2 drugs that Genentech currently has to treat CLL. Again, we don't have the time to go through both the efficacy and the safety. We could potentially do that at another time. I guess I'd prefer to open it up for questions at this point on CLL. I think I gave it the 7 seconds or 9 seconds are supposed to wait.
I think so, Linda.
Okay.
Thank you for your presentation. If anybody has any questions throughout the next presentation, feel free to enter it in the chat box. And if we have time at the end, we can switch over and have you discuss those. I definitely like your description of kind of packing the bone. I think that really helps to kind of clarify what the whole disease state kind of revolves around. I know oftentimes we're looking at tumors and things along those lines. So
Yeah, very good. Thank you so much.
yeah, thank you. And for our next presenter, I'm going to turn it over to Raina Rowan. She is an board certified oncology pharmacist with Massachusetts General Hospital.
All right, can everyone hear me and see my screen?
Yeah, I can hear you just fine.
Okay, great.
Your screen-
So as Austin said, my name is Brenna Rowan. I'm an advanced clinical oncology pharmacist at MGH North Shore Cancer Center in Danvers. Thanks to Oncoda for having me tonight, and I'm excited to jump into MDS-related anemia. So my objectives are here for you all to read, and we'll move forward just for the sake of time. And jumping into some of the background here. So in MDS, some of the cells in the bone marrow are abnormal or dysplastic and have problems developing normal cells. And then many of the cells that are already being formed are defective. And then these defective cells often die off, and the body also destroys some of the normal ones, which leaves this person without enough of viable cells. And different cells can be affected, but the most common finding in MDS is a shortage of red blood cells, and we know this as anemia. And it's important to note that in about 1 in 3 patients, MDS can progress to acute myeloid leukemia or AML. So looking at the MDS background, the median age at diagnosis is 70 years old, so definitely a disease of the aging population. And the number of diagnoses per year is 4.5 cases per 100,000 people. As I stated in the previous slide, the percent of cases that progress to AML is around 30%. And so the patient's symptoms, largely anemia is one of the largest noted symptoms, with shortness of breath, weakness, fatigue, bleeding, and chest pain being those symptoms that patients may complain of, as well as recurrent infections and fever. And so the MDS risk factors really aren't well elucidated, but they are kind of categorized as primary and therapy-related MDS risk factors. And so the primary MDS risk factors are older age, male sex, exposure to organic solvents such as benzene and agricultural chemicals, smoking, and radiation exposure. And then therapy-related MDS can be associated with alkylating agents, topoisomerase II inhibitors, and radiation therapy. And so for MDS workup, for the laboratory perspective, you're essentially working them up for their anemia to kind of elucidate what's going on. So things that you might be looking for are looking at a CBC with diff, reticulocyte count, red blood cells, folate, B12, ferritin, iron, and TIBC. And then on the other side, looking at pathology, it's important to look at a peripheral blood smear, look at a bone marrow aspiration. When you look at the bone marrow, that's the spongy tissue inside of the bones that's important for production of many different things, red blood cells, white blood cells, platelets. And then also look at cytogenetics. So how do cells really divide and replicate is the study of cytogenetics. And then looking at somatic mutations, these are things that happen in someone's lifespan that could develop as recognized mutations over time. And so for the WHO classification of MDS, the end story of this is that it's complicated. There are so many variants. We use the WHO classification for diagnosis and then other systems for risk stratification and treatment. So as I said, moving on from that WHO system, the risk stratification is made according to different prognostic scoring systems, such as the World Health Organization Prognostic Scoring System, IPSS and IPSSR. They really all have their advantages and disadvantages. Some clinicians use IPS to determine, their treatment, and IPSSR to determine prognosis. And the takeaway from this is think of this as step 2 after your diagnosis, determine treatment and prognosis. And remember that each system, when you're choosing it, or you won't be choosing it, but assessing it, has its own advantages and disadvantages. And as we jump into the treatment consideration, the goals of therapy and patient factors really go hand in hand. So for your goals of therapy, are we trying to alter the underlying disease or delay disease progression, improve quality of life, or reduce the number of transfusions? And for the patient factors, how does that correlate to goals of therapy? Are they older? What are their comorbidities? And due to this, are they transplant eligible? Because a lot of these MDS patients, due to being older, as well as having comorbidities, are not transplant eligible. And that depending on their specific symptoms and laboratory markers, are they asymptomatic, anemic, neutropenic, or thrombocytopenic, we may have targeted therapies that work better for their given symptoms or lab markers. In our first risk level of lower risk or asymptomatic, the key here is that essentially we don't treat them until they have symptoms or progression. And you would know that if they are assumably become transfusion dependent, in that they cannot maintain their counts and they're constantly coming in for transfusions. And so when you're looking at lower risk MDS treatment, this includes very low, low, and intermediate risk per IPSSR. One of the first drugs that we can use is lenalidomide, and we use this specifically in anemia with deletion 5q, anemia with a serum erythropoietin less than 500, we can use an ESA. Anemia with ring sideroblasts, we can use luspatercept. We can also use lower intensity chemotherapy. And all patients should be considered for a clinical trial if appropriate, as well as offered supportive care. And for higher risk treatment, which includes intermediate, high, and very high risk per IPSSR, the question that you have to answer is this patient a transplant candidate? And if the answer is yes, you can proceed with an allo, which if you remember is you're donating cells from a healthy person to the patient after they receive chemotherapy, radiation, or both. You can certainly do that if they are that transplant candidate. But again, a lot of these patients aren't. And so our treatment options aren't great. One of the most common things that we use is a chemotherapy category called hypomethylating agents, or even supportive care alone. And like our lower risk patients, all patients should be considered for a clinical trial, and all patients should be offered supportive care. So jumping into our first response question, FT is a 73-year-old male with no significant medical history. He has noticed an increase in fatigue and sore throat for the last month. When he presented to his primary care provider, his laboratory parameters revealed a white blood cell count of 4,000 cells per millimeter, as well as 40% neutrophils, a hemoglobin of 8.4, platelets of 110,000. And the patient is referred to your hematologist, who finds nothing remarkable on additional tests. However, the bone marrow biopsy comes back with dysplastic changes with 4% blasts consistent with MDS. His EPO level is reported as 157. His IPSSR category is low risk. And based upon this information, which of the following agents is the most appropriate to initiate? Is it an erythropoietin stimulating agent, filgrastim, luspatercept, or lenalidomide? So I'll give you a couple seconds to kind of think that over in your head. And the answer here is erythropoietin. The key things to kind of pick out: patient has low risk MDS, and the EPO level is less than 500. It's 157. So the chances of this patient responding to erythropoietin stimulating agents is fairly high. So that would be the most appropriate answer. And looking at anemia, it's important to go back to some cell lineage. And when you look at the blood cell differentiation into the myeloid line, you'll see that they can differentiate into red blood cells, platelets, as well as granulocytes. And so when we have a deficiency of red blood cells, just going back to basics, that would be considered anemia, deficiency in platelets, thrombocytopenia, and deficiency in neutrophils to be neutropenia. And so our lower risk MDS anemia treatment really mirrors kind of that overall treatment that we were talking about previously, with the exception of lower intensity chemotherapy. You can certainly use lower intensity chemotherapy. It just kind of tends to be later down in the plan for the patient. And we can use it for anemia, but it also treats all of those different symptoms that the patient may be having, be it anemia, thrombocytopenia, or neutropenia. And so our first targeted agent that we'll go into is lenalidomide. And it's kind of one of those drugs that you're like, what is this drug doing? There are so many direct and indirect effects going on here. There's really no one targeted thing that lenalidomide does in regards to MDS that makes it work. But the main direct effects are its anti-proliferative effects, as well as cell apoptosis. Indirect effects being T-cell mediated cytotoxicity and decreasing inflammation in the bone marrow environment. So for lenalidomide, we use it in lower risk MDS-associated symptomatic anemia with chromosomal deletion 5q, with or without other chromosomal abnormalities. And it's really important that we pick up on that chromosomal abnormality of deletion 5q. Really, lenalidomide doesn't work very well in MDS in the absence of that deletion. So it's important that those patients are being screened for that deletion and that they indeed have it. The dose is 10 milligrams orally daily. If you're familiar with multiple myeloma, this is a much different dose. It's lower and continuous as compared to in myeloma being a higher dose that we give cyclically. And our goal of treatment here is minimizing transfusion. The median time to response is 4.6 weeks and a median duration of response of 2 to 3 years. And for monitoring, there are some pretty important adverse side effects. And as with all kind of chemotherapy and oncology, we get used to this term of embryo-fetal toxicity, but with lenalidomide, it's one of the well-known ones. There's a REMS program due to it, and all providers, patients, and facilities have to enroll in this program. The other specific side effects include neutropenia and thrombocytopenia, as well as venous or arterial thromboembolism. Patients need to be on antithrombotic prophylaxis to reduce this risk. At a minimum, low-dose aspirin, and if they have more risk factors, certainly they can even be on low molecular weight heparins or DOACs. And for our next category of erythropoiesis-stimulating agents, these agents act on the erythropoietin receptor located on red blood cells and help signal the proliferation and differentiation of red blood cell precursors. We use this ESAs in lower risk MDS with symptomatic anemia and serum erythropoietin level less than 500. The doses are listed for you there, but I will mention that in clinical practice, at least in the outpatient setting, Darbepoetin alpha, which is a pegylated form of epoetin alpha, is much friendlier to use due to extended dosing, even every 2 or 3 weeks as opposed to weekly. And for a chronic med, that's really important for a lot of our patients. The goal of treatment is to decrease transfusion. The median time to response is around 3 months, and you can add granulocyte colony stimulating factors such as filgrastim to increase response, but really in practice, this is very rarely done. The ESAs available in the US are categorized into the short and long-acting categories. Really, there's only epoetin alpha as well as the biosimilar, as well as darbepoetin alpha. And so when we're monitoring ESAs, we know that the class-wide side effects are similar, but there are some pretty scary, serious side effects, including increased mortality, myocardial infarction, stroke, and thromboembolism. So we do have several methods to mitigate this risk. And the first is that we use caution as the hemoglobin approaches 11 grams per deciliter, and definitely avoid as we're approaching 12. We want patients to have good blood pressure control and to ensure compliance with antihypertensive and lifestyle modifications if applicable. And some more clinical pearls. We want to correct iron deficiency prior to initiation of therapy. If you're thinking back to some of those side effects that I was mentioning, they're pretty severe. So we want to make sure that all of our bases are covered here and that all forms of anemia are corrected. And the first step to that is correcting iron deficiency. So we would want to do that before going to an ESA. We don't begin ESAs unless their hemoglobin is less than 10. We can certainly target something above 10 once they're on therapy, but to initiate, because we don't know how far they're going to jump, we don't want them to start unless their hemoglobin is less than 10. And we really use the lowest dose possible to reduce transfusions. That's our goal, as well as to minimize adverse side effects. And luspatercept is kind of our newest drug on the block. It was the first drug approved for MDS in over 15 years. And it essentially promotes erythropoiesis and maturation of hemoglobin and red blood cell concentrations via reducing SMAD2 and SMAD3 signaling. And the use of luspatercept was validated in the MEDALIST trial, which looked at the specific morphology of MDS in patients that had ring sideroblast. They also had to be lower risk, ineligible or refractory to ESAs, and red blood cell transfusion dependent. And the primary endpoint of this study was looking at red blood cell transfusion independence for greater than or equal to 8 weeks. So when you're looking at the primary endpoint here, we have our y-axis of percentage of patients and x-axis of number of patients with response. The first column looks at that primary endpoint of transfusion independence at 8 weeks. And you'll see that around 38% of patients were red blood cell transfusion independent. And you may be thinking that's not significant, but for a lot of these patients, they come in for 2 units of blood a week. So to be completely transfusion free for 8 weeks is very significant. And so like the MEDALIST study, our indication for luspatercept is for patients that have ring sideroblast, as well as that transfusion requirement. We have a titration-based protocol that we use when dosing. Our goal of treatment, like many of the other drugs that we've been over, is to minimize transfusion. And the median time to response is very quick. 90% of patients respond with their first dose, which is pretty impressive. And the median duration of response for transfusion independence is around 31 weeks. So luspatercept dosing, it's complicated. But the takeaway here is that we titrate the dose based on transfusion requirements until a maximum dose is reached. The therapy is held when hemoglobin is greater than or equal to 11.5, and the dose is reduced when the hemoglobin rises too quickly. For monitoring, as far as efficacy goes, we want to look for a decrease in number of transfusions. We review the patient's hemoglobin and blood pressure prior to each dose. We may need to increase the dose if transfusions are not decreasing, and there is a maximum dose of 1.75 mg per kg for 3 doses. But if there is no reduction in their transfusion number after these 3 doses at maximum dose, therapy should really be discontinued because it's not working at that time. And for toxicity, luckily side effects actually decrease with continued use and are not associated with dose increases at this time. The main ones to look out for are diarrhea, asthenia, back pain, and hypertension. So our second audience response question here, while awaiting cytogenetics analysis of a bone marrow sample from an MDS patient, the team you're rounding with asks you if there's an oral option available to treat MDS, and you answer lenalidomide. Lenalidomide is most appropriate in an MDS patient with which of the following cytogenetic features? Is it a deletion 13q, deletion 5q, deletion 17p, isochrome 17q, or a duplication 1q? I'll give you just a couple seconds to think that over, but I think we've gone over it pretty in depth. And recall that we did talk about how lenalidomide is best used in patients that have deletion 5q. And for hypomethylating agents, over time with MDS, there's an abnormal methylation process. And when we have hypomethylating agents, they help with this process, specifically with MDS. And so for our dosing of azacitidine, it can be given IV or subcutaneously. The FDA approved dosing is 75 mg per meter squared per day for 7 days of a 28-day treatment cycle. But to be honest, in clinical practice, we tend to use the alternative dosing schemas below. We usually do a 5-day schedule, Monday through Friday, and repeat it every 28 days. Again, a lot of these patients are elderly, and we want to balance of maintaining quality of life here. So that dosing schema is very important. And essentially, patients can continue treatment as long as they continue to have a benefit, and they should be treated for a minimum of 4 to 6 cycles. They do take time to work. Our next HMA is decitabine, and there are 3-day and 5-day regimens. In practice, we tend to use that 5-day regimen, so you don't have to do an every 8-hour dosing. And new to the market is a oral option, decitabine and cedazuridine, which is 1 tablet that you take on days 1 through 5 of each 28-day cycle. And it's considered bioequivalent to IV decitabine, but it is important that you aren't interchanging products within a particular cycle. Like I said, with HMAs, they take time to work. So at least 4 to 6 cycles, these patients should be on these drugs. We continue treatment as long as patients continue to benefit. And for toxicity, nausea and vomiting, injection site reactions, remember azacitidine can be given subcutaneously, thrombocytopenia, neutropenia, and rarely TLS. And lastly, looking at transfusions, red blood cell transfusions, CMV safe, are recommended for symptomatic anemia. And this is regardless of whatever therapy the patient's on. If they're symptomatic, they should be transfused. And irradiated products are suggested for transplant candidates because we believe that these irradiated products have less chance of graft versus host disease. And iron overload goes hand in hand with transfusion, simply because iron overload starts to develop in MDS patients before they even become transfusion dependent due to their ineffective erythropoiesis, as well as once they are transfusion dependent, they're consistently getting transfusion, and each unit of blood contains between 200 to 250 milligrams of iron. So the chance of them getting iron overloaded pretty quick is very real. And this has significant morbidity and mortality, particularly with the liver, heart, and endocrine system. And for iron chelation therapy, we used them for so long, but until recently, the publication of the Telesto trial, we really didn't know if there was any advantage of using them. And with this trial, we did find that there is an event-free survival advantage of using iron chelation therapy in MDS, but at the expense of adverse drug effects. And so this is a very quick summary of iron chelation therapy. I would say that these are very dirty drugs. So whenever you have to use these, please refer to the individual packaging. Their dosage forms are complicated. They each have very unique adverse drug effects. It's not a class-wide effect. But the main thing to think of is that all formulations should be titrated based on serum ferritin. And in general, when serum ferritin is consistently less than 500, consider temporarily interrupting therapy until it's greater than 500. And so our last audience response question to reflect upon is true or false, oral decitabine cedazuridine has been shown to be bioequivalent to IV decitabine and is currently FDA approved for use in patients with MDS. True or false? And as we said previously, they are considered bioequivalent, but we wouldn't want to interchange them within one particular cycle. And ending right on time. If you have any questions, feel free to enter them in the chat or speak up now.
We did have a question come in. So as you're looking at the IV decitabine versus the oral bioequivalent, how do you kind of manage that, and how do you decide which one to use for which patients?
So I would say it depends on your patient. Surprisingly, a lot of your elderly patients feel more comfortable coming into a clinic every day to get their medication. But you know, it is kind of patient specific. There's nothing that I would say there's no data saying one is better than the other. So it tends to be down to the patient, what they're most comfortable with, as well as from a compliance perspective. Are you sure that the patient is able to take 5 days of oral medication consistently? So patient specific factors.